Okay, I think we can start. Is that okay, Cheryl?
Yes, it's all good.
And can you see my shared screen?
Yes, I can.
Well, thanks. So good afternoon, everybody, and thank you for joining us today. First of all, again, just to thank the Gastro Foundation and also Project GECHO from the University of New Mexico that help us to host these sessions. They held weekly on a Wednesday. The last check we had, I think, was around 50 registrations from about 15 sub-Saharan African countries. During the meeting, the chat will be open for any questions or comments. So today we thought that we would just run through a number of interesting cases that were shared with us from colleagues from Zimbabwe and also Namibia, and then and also Kenya. And if time allows, we will eventually just show one or two cases from South Africa as well, I think, that have some valuable learning points. So honestly, I think you had the first presentation, so I'll just put up the patient case, and I think that does project now. So you can take us through that, and then I will show the imaging, and you can just comment on it. So I just want to introduce Dr. Shiaka. He's a hepatopancreatobiliary surgeon that trained in Cape Town with us, and now back in Harare, I think, is the only HPV surgeon in Zimbabwe. So very nice to have you on our side. I really like your background there. We all dream of that.
Thank you very much, Prof, for the kind introduction, and also for the opportunity to share this case that we hope to discuss and have a treatment plan for. So I'm going to quickly go through the case. It's a 64-year-old male patient who is a high school teacher and has been quite active in sport. He's also one of the sports teachers at the school. On his social history, he occasionally drinks socially, and he has never smoked. And of note in the family history in terms of malignancies, his sister passed on from colon malignancy a couple of years back. He's a non-hypertensive who's well controlled on atenolol. And his history that he came to me with was that of an epigastric mass that he noticed a few months back, which was gradually increasing in size. And it was now getting associated with early satiety and some worsening dull epigastric pain. By the time he came to me, he was now requiring some tramadol to manage the pain. So when we examined him, he was actually quite a fit gentleman. He was not pale, he had no jaundice, and he was hemodynamically stable. He didn't pick up any lymphadenopathy. On an abdominal examination, I noted this quite big mass in the epigastrium, and it was extending into the left upper quadrant. It was moving well with respiration. And his performance score was 1, maybe just because of the pain, really. And the investigations we did, and full blood count showed an HbA of 12, just a mild anemia from our side. A white cell count was normal, and this platelet count was 250. INR was 1.3. His kidney function was essentially normal. Total bilirubin was 20. He had some increased transaminases with an AST of 643, ALT of 153. ALP and GGT were also mildly elevated at 173 and 134 respectively. Albumin was low on 26. So a hepatitis screen, we did the surface antigen, surface antibody, and all of those turned out negative. And his hepatitis C was also negative. But of note, his alpha fetoprotein was 1,650. We did an endoscopy which showed no varices or any portal hypertensive gastropathy. And on cross-sectional imaging, we did have a CT scan, which we're just going to show in a second. So we did a chest CT, and this one is an uncontrasted CT. There was in the chest there was no nodules to pick up, no evidence of metastasis. But when we came down to the abdomen, we noted this huge heterogeneous lesion that we can see in the left lateral segments of the liver. And it's quite pedunculated, and it was extending well down into the abdomen. There were a few shorty periportal lymph nodes, but nothing else of note, and there was no ascites. So we will probably go to the arterial phase and see how that lesion looks up. It was quite heterogeneous. It took up some contrast quite avidly in the arterial phase, which I'll just see in a second. Notably, there was no ascites. So it was quite heterogeneous and takes up some contrast, but essentially it remains hypo enhancing. And like I said, no ascites, no evidence of any extrahepatic lesions. And on the venous phase, some relative washout, all of which would be in keeping with what we think is hepatocellular carcinoma. And when you looked at the liver surfaces, there was no evidence of any liver cirrhosis, and the portal vein was not very prominent, and the spleen was not enlarged. So this is what we think. This is a hepatocellular carcinoma with a negative hepatitis screen and no obvious radiological evidence of liver cirrhosis. So that's the case that we have here that we hope you'll be able to help us with treatment plans.
Hi, Anusai, Mark here. I just was wondering the relationship of it to the right portal vein and the hepatic veins and the main portal vein. Do you think those are clear? Maybe we can just look at that imaging again. I don't know if it's going to be easy to do that.
Yeah, maybe we just need to go through it again, but the right portal vein looked clear, but the left portal vein looked like it was squashed by the tumor. But I didn't quite see anything within the vein itself, but the left portal vein is obviously compromised there. But if we could probably just go through the picture again.
I'll just share it again. Is it sharing?
Yes,
Yeah.
it is.
So I'm just going to go through the portal venous. Okay, so at the top there, I think, Mark, it's very close to the middle hepatic vein. And if you come down the portal vein, I'll just go up again. Yeah, so
it's well clear. So I mean, it's the right hepatic vein is clear. The right portal vein is clear, and the main portal vein is clear. I worked out his Child-Pugh score as being 6, and I think that's mainly because of the albumin.
The albumin.
You know, when you look at that liver, it doesn't look cirrhotic, but the INR is 1.3, and you've got an albumin of 26, and it doesn't sound like there's particularly good reason for that. So I mean, I would, and then the other thing is that the hepatitis B screen is negative. So you're going to end up taking out half of this guy's liver. I mean, I don't know what everyone else's thoughts are, but I would want to know maybe if the right side of the liver is cirrhotic, and whether it's worth putting in a lap scope or getting a biopsy of the normal right side of the liver. Just a thought. I don't know. Rashid, what are your thoughts on that?
Yeah, obviously, I also didn't see any features suggestive of cirrhosis. And I was just thinking that if Onesai has, we know that the tumor is mostly on the left lateral segment, and it's very close to the portal vein. I don't know, maybe he can apply TACE. See, maybe it will shrink to resect, or yeah, because I don't know whether he will have problems with the future liver remnant, and whether a lateral segment resection will actually cause problems. I'm not too sure, but I was wondering whether it stays as an option for neoadjuvant treatment before resection. Have you ever done that in Cape Town, or I don't remember?
So we have done that to shrink. There's a couple of reasons to do that. I mean, you can do it to try and shrink the tumor down. The other thing that, you know, if you looked at this patient's alpha fetoprotein, it's 1,650, and you know, you'd be reluctant to transplant someone with that, but we would consider going ahead with a resection. But you know, that is a poor prognostic factor. And the other thing is, operating on someone with an albumin of 26 is a little bit concerning. It would be nice to be able to maybe get the albumin up. You know, if you look in the treatment algorithms, it wouldn't be suggested to give TACE, because I think this thing is potentially resectable, but there's a couple of features that might make you want to just delay things and try and get the patient in a bit of a better condition and maybe get some more information. So, I mean, I would think it would be nice to get volumetry of the bit of liver that you're going to leave behind. It would be nice to know if it's cirrhotic and maybe get a biopsy of the liver that you're leaving behind. It might be nice to do a TACE and see that the alpha fetoprotein does decrease, and maybe if you treated the cancer, maybe the albumin would be available.
Sorry, so my other concern there, Mark, was if you look at the LFTs, she actually has quite a bit of transaminitis, which probably may also be part of the reason why he's got a hypoalbuminemia. I wasn't quite sure how that was, what caused that. From his drug history, I don't have anything that could suggest reasons why he's got that transaminitis, but obviously one would want to let that one settle probably before we
and then you mentioned, I mean, you mentioned in the history alcohol, and we don't have another etiological factor in him because hepatitis B is negative. Like, is alcohol, like, do you think it's very significant, or?
From what he said, it's more like a social, you know, occasional drinker every so often on parties and stuff like that, but not everyday thing. So there is a history, but some patients will underestimate their intake, but it doesn't look like he's a heavy drinker now.
So is TACE available?
Yes,
you have a
yes.
radiologist who can do TACE.
We do have TACE available, yes.
I mean, I don't know what anyone else thinks. I mean, I don't see any comments, but I think trying to get him into a slightly better state with a higher albumin and seeing if you can improve things a bit, get volumetry done, and maybe get a TACE done and see what the alpha fetoprotein does. You know, the other thing would be whether you should consider, you know, if the volume is small and he's got cirrhosis, a portal vein embolization, but portal vein embolization is not supposed to work as well in cirrhotic livers, but it's also something that could be considered. Ed, I don't know what your thoughts, what do you think?
Yeah, Mark, no, I agree with you. You know, if we look at the principles of or what is applied in transplantation at the moment is exactly that. So a patient with this size tumor that would probably fall outside of most or the guidelines mostly applied by people, you would hear that one would probably go for a TACE and to test the biology, to maybe make it a little bit smaller and see if that alpha fetoprotein comes down. So the reason why we would operate on this guy probably in any case is because we assume resection as a lesser procedure, and the guy's not in the queue for a liver that can be used by somebody else. But the question is, if we really do patients a favor with resections, if you don't get a response on the alpha-fetoprotein. So I think we must think more critically about the way we do it. You know, the fact that a technical operation is possible doesn't mean that it necessarily makes oncological sense. And we're moving into a new era where we like to test more and more tumors for the biology before we would proceed with surgery, in spite of the fact that the tumor is resectable.
There's a comment. I'm just going to read it. Is it okay to conclude that this is a HCC radiologically in the absence of cirrhosis or hepatitis B infection? My understanding is the LIRAD conclusion for HCC requires pre-existing HPV or cirrhosis, where the PPV justifies the radiological diagnosis. There's some few other tumors that can also increase alpha-fetoprotein to the level apart from HCC. So I agree that that is that there are other tumors. I must say we don't know that there's not cirrhosis here. In our setting, we would be quite happy to make the diagnosis of an HCC based on the imaging and the alpha-fetoprotein, and we are concerned about the risk of a biopsy causing bleeding or seeding of the tumor. So I don't know if anyone else has any thoughts on that, but I certainly think that there's a trend away from biopsying these tumors.
Yeah, I think, Mark, just a comment on that. I mean, this patient is a full LIRADS 5, and we know the sensitivity and the specificity is probably 100% or very close to it. And we still see, unfortunately, still people where the diagnosis is very, very clear on imaging that are biopsied with the risks that we know are associated with that.
You know, the germ cell tumors and these other tumors that cause raised alpha-fetoprotein are exceedingly not common in adults. And in a patient of 66, I think this is an HCC and should be treated like that. Yeah.
So honestly, I think the consensus here is to offer the patient an operation. So just again, do you have a possibility to taste?
Yeah, he does.
Oh, okay.
Yes, yes, we can taste it. Yes, from this imaging, we don't seem to see any evidence of metastatic disease, and very minimum evidence, if any, of cirrhosis. So when we look at this one, non-cirrhotic HCCs with that size and that very high alpha-fetoprotein, are we happy to be just using the CT to make sure we don't have any extra disease?
That was a question. Honestly, when I was writing down questions at the beginning, it was a little note that I made, like CT versus MRI, whether we should get a primavist MRI. You know, if you can, I think it's better to get it, because you don't want to go through this whole process and now there's satellite lesions on the left. It will also give you more information about the primary tumor, which sort of ties in with this question about whether it is a HCC or not. So I don't think it's ever wrong to get an MRI. It's just that there's the cost and the logistical factors about getting it. And if that's not a problem for you, then I definitely think it's a worthwhile thing to do.
Yeah. We can get an MRI scan, but not the primavist. We don't have it. The best we can get is a gadolinium.
Well, I still think that that's probably better than not having it.
Yeah. Okay. So probably what we'll do then is maybe I'll do an MRI. If we don't see any extra disease, maybe we can offer him a taste and see how he responds, and probably follow it.
And maybe, I don't know, when they do the taste, is it worthwhile? But so the other thing that we didn't mention is you can do, I mean, we got it available now, but I mean, you can do elastography of the right side of the liver, but you know, it is really nice to know if you are dealing with a cirrhotic liver or not. I suspect that it is cirrhotic.
Yeah,
and
all
putting in a
fibrotic-
lap scope or just getting a liver biopsy of the right side gives you more information as well.
Yeah, and I think and also fibrosis. I mean, we don't really know how that affects the function, but I think one needs to be careful. Just a note or a comment on the MRI that we shouldn't confuse colorectal mets with in terms of detection with colorectal, sorry, with HCC. So usually the detection is not a problem in HCC because of the imaging features that you do have usually enhancing lesions quite clear on the arterial face. So I'm not sure in a case like this that that an MRI necessarily helps us, and we first of all look for lung metastases. And if we're worried about peritoneal metastases, we know that all of the imaging methods are not good. And there you're probably better off by putting a laparoscope.
It's a nice operation. I hope you get to do it.
Yeah. No, thank you very much for the input.
Okay, so Mark, I'm just going to move on to the second case. I see Karan has joined as well. So let me just screen share here. Right. Go. Okay, so it's really a pleasure for me to introduce Dr. Nashidengo from Windhoek. He's also a fellow that trained with us and now the HPV surgeon in Namibia. And thank you very much, Rashid, for sharing this case with us.
Thank you once again, Prof. It's always a pleasure to see you and to also present our case. It will be really nice to actually get an idea and the way forward for this young girl. She's 16 years old. She was referred to me by a GP with abdominal mass. She's a student in grade 10 in one of the nearby towns about kilometers from Windhoek. She lives with her parents, no history of smoking or alcohol use, no relevant family history, and she doesn't have any prior history of hepatitis B or any infections or drug reactions or anything like that with regards to the liver. And she presented with a right upper quadrant pain, and she could feel a mass in the abdomen. She never had any history of, and she was not really jaundiced. No, she's not on any medical medications. On examination, she's average build with a BMI of 22. No signs of chronic liver disease or portal hypertension. The abdomen was not really distended, but you could see a mass in the right upper quadrant. And on palpation, it was hard, and she didn't have any ascites. Her performance score is a 0, and the Child-Pugh score is a 6. The liver functions were not really that impressive. A bit of elevation in the ALP and the GGT, but the transaminase were actually normal. So we proceeded to do a CT scan. So this is an uncontrasted CT scan of, yeah. So just in terms of the other workup, the hepatitis B surface antigen was negative. And her RNR was not elevated. Her alpha-fetoprotein also not elevated, less than 2. Yeah, and albumin was fairly preserved at 34. And she didn't have any other signs of infections or anything like that. So we're just going to look at the CT scan. She had an ultrasound which demonstrated an abdomen, a liver mass, very large. I can't remember the dimension, but more than 15 centimeters in size. And this is a CT scan that we're reviewing now. So this is an uncontrasted face. So you can see an impression of the in the central part of the liver, a hypodense or a mass in the liver there. and she didn't have any ascites or anything. There's a bit of calcification within the mass there that we could see. And then going to the arterial phase. Yeah, so this is arterial phase. We could see the heterogeneously enhancing lesion, mostly encompassing segment 4, and there's a bit of segment 8 and 6 is quite huge, and is almost very close to the common hepatic artery. You can see that obviously it's enhancing compared to the rest of the liver. Again, we don't see any ascites. That is quite obvious, and we see also that the left lateral segment is actually clear of the tumor, and there's a lot of mass effect actually on the tumor. The gallbladder is very squashed. And then going to the venous phase, in the lower cuts of the chest, we didn't see any nodules. We didn't do a formal lung CT scan, although it was probably required. And then this is the venous phase. You can see that there's a bit of compression in the portal vein. The portal vein is actually quite patent, and you can see there's a bit of a washout phenomenon demonstrated with the mass. We didn't really see any obvious lymph nodes around, but if you go up a bit, Prof, we got the impression that maybe the portal vein on the right side was a bit. I'm not quite sure whether it was infiltrated or maybe just a mass effect. And there's not really much biliary duct dilatation in the liver, but we're very much worried about the right portal vein, whether there was a tumor thrombus or maybe just a compression effect. Yeah, so we were quite happy that maybe we are dealing with a hepatocellular carcinoma, maybe a fibrolaminar type. But there's also a huge differential being a 16-year-old. Could this be a pathoblastoma or any other childhood tumors like maybe sarcomas and things like that, or embryonal sarcomas? And I would really want to think what the audience thinks and what would be the plan forward for this 16-year-old. Whether do you go ahead with the resection? We got the calculation that the lateral segment was quite, it looked a bit hypertrophied. We think if we were to do a surgery, would it be like an extension, or would you do a biopsy first, seeing that the alpha-fetoprotein not elevated and she doesn't really have known risk factor for hepatocellular carcinoma? So it would be nice to see what the audience thinks. Thank you, Prof.
Yeah, Rashid, if I'm not mistaken, you did send these pictures to Professor Benningfield as well. Rashid, could you hear me?
Yes, I didn't hear you, Prof. What did you say?
No, I just asked, did you send these pictures on to Professor Benningfield as well? Because this is clearly a very complicated case, and the differential diagnosis or the diagnosis would be very important the way forward.
Yeah, yes, I did send the images to Professor Benningfield, and he was also leaning towards a possible hepatocellular carcinoma. In fact, he got us the calculations for the estimated future liver remnants of the segment 2 and 3, which I can't remember offhand, Prof. I think it was probably more than 30%, but I can't remember the exact number. But he was also more leaning towards the hepatocellular carcinoma. And he's actually the one who pointed to the fact that maybe there's a tumor infiltration of the right portal vein, Prof.
So can I just say something? The hepatitis B, I see that it's only surface antigen. Have you done a core antibody?
That one, I can't, I checked on the system because it was actually referred to me, and I don't think it was done actually. So,
you know, if
yeah.
the core antibody, if the total core antibody is positive, then I think it makes it much more likely that this is a HCC. So I would after request that, because I think then you can, then you have a risk factor.
Mm.
And it makes it much clearer. I just the glimpse of it, I thought there was maybe tumor in that vein. I was just worried in the one area on that scan whether there was some tissue sort of in the patagidial ligament as well. I don't know if we can have a look at that again, Ed.
Yeah, we can do that. I'll just go, I think probably the portal venous phase is going to help us most
Yeah.
there.
Mm.
I'll just go through it slowly.
Just around about there, but maybe it's just
Yeah, I think it's very
if you look down towards where the aorta is, where there's a little tongue of tissue lower down coming out. I mean, I don't know.
Mm. I think what we see there is pancreas.
Yeah,
Mm.
yeah.
That
But
is
between the pancreas and the aorta there,
a very small aorta, and then you get a pancreatic duct there. Sorry, a bit of a pancreatic duct, and I think that's the head of the pancreas we see. I think a key question here is if one should, if against of what we usually do, is whether that you need to do a biopsy of this before we proceed.
Yeah.
yeah, and then just said that portal vein again, the left portal vein. Let's just go up to see where we think the vein it might be.
Yeah, let me just get it there. Sorry, I mean arterial phase.
No,
It's arterial
Also-
phase.
We'll just move to,
I also just wonder here whether an MRI might also be useful. How difficult is it to get an MRI, Rashid?
No, not difficult at all, Mark. We can easily get the MRI for her. Yeah.
You
Yeah,
see
so-
there, that portal vein looks to me like I just worry, is that just pancreas or?
let me just move again here. Yeah, so the problem is the pancreas has got a little bit the same attenuation or the same signal or the attenuation as the tumor in that area, and there you maybe see a hint of a plane, but I think the size of this tumor will disperse any fat between the pancreas and the tumor itself. Just one observation is I think that the gallbladder is actually completely squashed over to the, was like a left-sided gallbladder.
Yeah, to the left side. Yeah. Yeah.
And just the way that the tumor grew, if that is the case, it must have started in segment 5, probably more in segment 5, and then dispersed it, and maybe segment 4 sort of just completely compressed again segment 2 and 3 that you see there. Just we had that comment in the previous patient as well. When you have a portal vein embolization, tumor growth inside the portal vein, they do differentiate nowadays between a central tumor thrombus and a peripheral tumor thrombus. Because with a central tumor thrombus sitting in the common hepatic, the main portal vein, or very close to the bifurcation, the potential for metastases through the portal vein system is also into the future liver remnant if you plan a resection. Whereas if it's more peripheral, it will only embolize, it won't go against the stream, embolize to that segment or sector in which it is. So I think we must just be careful. The stratification has to be done, and I think it's being done, and there will be more evidence that portal vein embolization, portal vein thrombus, tumor thrombus is not the same in all patients. That in some patients it's more peripheral, and the future liver remnant at least wouldn't have wouldn't have metastases on the basis of portal vein infiltration and tumor thrombus further down the circulation.
There are no comments further, Ed. I was just wondering, by thinking aloud, whether, if you get an MRI, and it will probably shed more light on whether there is tumor on the portal vein or not. And if there is, that makes HCC more likely. you know, if the MRI that is still a little bit inconclusive and the hepatitis B studies are all negative, then I wonder whether a biopsy in this case might not be indicated, because we don't really have a risk factor and the patient is young.
Yeah, I think the problem is just that we don't have a radiologist, and if we have a radiologist, please speak up. But I think the depiction of the vessels on the MRI can be as good, but it's not necessarily better than a CT. So I don't know if it's going to give you more information on that point. So if we assume that this is a HCC, do you think there's a place for a TACE in this patient?
Yeah. What do you think, Rashid?
Well, we did think about it, and we couldn't see any contraindication to a TACE. So the only thing is that, okay, it's mostly on the right side and also on segment 4. And the portal vein, the main portal vein is not thrombosed. It's mostly a possibility on the right side. So we did think that she is a candidate to do a TACE. And we do also have TACE available in Windhoek. We initially started with coils and things, but now we've moved to microspheres. So we do have TACE available, and I didn't really see any contraindication to TACE in this patient. So that we did consider it, yeah.
Okay.
I think I probably would agree. To me, the tumor is quite central and quite huge. One would want, if to make it technically easy for any resection, to have that tumor to shrink, and obviously a TACE probably would be quite useful. I see the left lateral segments are quite hypertrophied. Do we have the volumetry for that one?
Yeah, I was just looking through my phone, my email from Professor Benningfield, but I couldn't find it. But I remember it was good, more than 30%, and in the absence of physical features of cirrhosis and portal hypertension, then yeah, we thought it was I think it was more than 30%, but I can't remember the exact figure on the side.
Yeah, I think I agree with you guys. I think a TACE is quite nice here, you know, for the same reasons. You test the tumor biology, and it might make the surgery easier. Yeah, this is whether you need a biopsy or not. You know, we are very anti-biopsy. So, but I do accept that the differential diagnosis here is a bit bigger than normal.
Yeah. Okay.
Mark, I see that. I mean, you normally, if you biopsy this, you would like to go through normal liver, and there may be a window here that where there's a little bit of normal liver left here in segment 6-7 to pass that and to get a needle into the tumor. But I think that at the end of it, if I have to sort of rank the differential diagnosis, probably an HCC, and I wouldn't be surprised if the core antigens is negative, is positive. There's one other thing that I thought about saying now, but I think Rashid, we're nice to have feedback on this patient somewhere down the line, and
yeah,
where we went with this, yeah.
Yeah, we'll do definitely. Yeah. So the consensus is to do an MRI and yeah, get the radiologist to review it again. Is it? Oh. And no biopsy for now.
Yeah, it's a difficult one. I was wondering, you know, because the although that's what I wanted to say is, even if it's a focal fibrolamellar, there is some data on using TACE in fibrolamellar tumors, and Mark has actually put together a nice little systematic review on that. So it has been used. There's not a lot of data on it, but my guess is that it does offer you some of the advantages that it does in HCC.
Okay.
All right. I think that was it. So I'm just gonna move on to Dr. Gandhi's case. Karan, are you on?
Yes, Prof. Hi.
Hi, welcome, Karan. I know
Thank
you
you
were
very
in
much.
hospital now, and
I
but
was, yeah.
so Dr. Gandhi is surgeon at Aga Khan Hospital in Nairobi, and he had this case that he was going to share with us.
Okay. Thank you very much, Prof. Seem to have lost the screen. Is it just me, or is this
I'm going to stop share and just share it again.
okay?
I'm just going to share it again to see if it comes up. You see
Yeah.
it, Karan?
I see it.
Okay, so you can just go.
Okay, great. So thank you very much for the opportunity. The patient I'm presenting is Mr. FNM. He is a 52-year-old gentleman who works as a driver for the UN, and he is of Ethiopian origin. He was referred to me after having had an MRI, but basically his history is positive for a very strong alcohol use, that he stopped 5 years ago, where he was actually diagnosed with liver disease, but that was the only information he had. He's also an ex-smoker, and he stopped smoking at the same time when he was diagnosed with liver disease, when he stopped drinking alcohol. He's married with 2 children, and at the moment he doesn't smoke or drink anymore. There's no positive family history of any malignancy, and he is a hypertensive but well controlled on treatment with no other comorbidities. He had a screening ultrasound done, and that's how this liver lesion was picked up. And then he was referred to me after having had an MRI after the liver ultrasound. So clinically, he's quite a well-preserved gentleman, good performance score of 0 in good general condition, slightly on the obese side, but no pallor. He was not jaundiced either at the time of the referral, and he had no edema or clubbing. There was no palpable lymphadenopathy either. On abdominal examination, apart from the increased adiposity, there was no distension, no clinical ascites, no features of chronic liver disease, caput medusae, or anything like that. And there were no masses palpable on his abdomen. His abdomen was very soft and non-tender as well. So, like I mentioned, his ECOG performance status was 1 with a Child-Pugh score of 5. Sorry, I didn't calculate the MEL score there. But as you can see from all his liver functions down there, they're quite remarkably normal, mildly elevated gamma GT. But apart from that, everything else was quite normal with an albumin of 43. So he had good synthetic function, and his INR was also normal. He was a bit polycythemic with an HB of 17.1, but apart from that, and slightly low platelets, but maybe some features of portal hypertension based on that. But his UECs were completely normal, and his hepatitis screening was all negative. But he just had screening tests. He didn't have a core or an E antigen for the hepatitis B, but the surface antigen was negative, and hepatitis C was negative as well. He had an alpha fetoprotein of 594. And he had, like I mentioned, an ultrasound and an MRI, but I requested a CT scan for him prior to resection just to assess the vasculature. And I think we can go over the CT scan that we did. So on this CT scan, you can see that there are no obvious lung lesions, and the liver is quite visibly shrunken, quite separated from the abdominal wall as we were higher up, and just about now you can sort of see a well-defined lesion in segment 6 or 7 of the liver. Maybe if we can just, yeah. So this is the mass that has some arterial phase hyperenhancement. There was another arterial phase on this scan, Prof. I'm not sure if you managed to see that one or not, but it was showing it a bit more clearly. Of note, you can see that the caudate lobe is quite enlarged on this CT scan as well. And you can see that there's quite a wide umbilical fissure, and the gallbladder seems to be separated from the liver as well. So those are frank features of cirrhosis, and those are that's what we have. So what I'm thinking is that this is a hyper-enhancing lesion in arterial phase with the significant history of cirrhosis. So obviously HCC was very high in our differential, and we had the alpha fetoprotein of 594 as well. I think other than that, there was not much else to report of this scan, not much else positive. And we can just maybe look at the portal venous phase as well.
I think that's what I've got up here. Currently, unfortunately, not all of them would download. But
Oh, right.
yeah. But I think you've got a mixed phase here, but you do see a little bit of central washout probably in the tube.
Washout. Yes. I actually, if you don't mind me sharing, I might be able to share from my screen.
Yeah, just one thing, Karan, there must just not be any identifying information of the patient.
Yeah. Okay, no, there is. So
Okay.
right. Okay, so then we need that.
Yeah, but you can maybe just fill us in on if there's anything else that I can see on these projections.
Nothing else that was of note in these projections.
Okay.
That looks like the IVC.
Yeah, so I think you do see the IVC. It's sort of in between phase, but you see the IVC there, and it seems like you've got quite a good distance
Between, yeah.
from the tumor. So I think there you can see it. So the tumor is here.
Yeah.
That is sort of partial filling of the IVC over there.
Yeah, and it was quite a well-defined tumor. The portal vein, there was no vascular invasion that was obviously noticeable. No venous invasion, and the hepatic veins were all quite patent.
Yeah. So it's just interesting if you look at this, because it seems like the missing liver here has been inhabited by the colon, almost like a kind of a Chilaiditi scenario.
Sign. Yes.
It seems as if both segment 5 and 8 they're just not around. If I have to guess what's going on here. Unfortunately, it's too early to see or at least maybe segment 4 otherwise that is just sort of atrophied. Because if that is the gallbladder, that should be segment 5, and then the wedge is gone is segment 4. So that may be the case. So any comments? Just also on the Igemban Kandala has had a comment on the previous patient. I think that is very valid, that we can come back to after yours, Karan. But further management of this patient, how were your thoughts?
So I thought that it's a relatively small HCC with not a crazy elevated alpha fetoprotein, just 594. And the patient despite being cirrhotic, had a good Child-Pugh score. He has a Child-Pugh A and a score of 5 with a good albumin as well. So I actually elected to go in for a resection, just a parenchymal sparing, volume sparing resection. Although this is out of I think it was about 3 centimeters, the lesion. So my thought was to go in and just do a local resection of the tumor.
Yeah. So this whole story that we've just discussed about portal vein or possible portal vein infiltration. So clearly there's not portal vein infiltration. There's no portal vein infiltration of the main portal vein to segment 6 and 7. But one must also keep in mind that there's portal vein, maybe portal vein infiltration on a smaller level or in smaller vessels and even microscopic.
Yes.
Wouldn't that be a better strategy in this patient, to just do a segmental resection of segment 6 and 7, or for that matter, even a right-sided hemiapatectomy, because you've got quite a, I'm just going to page through it again, quite a substantial chunk of all of this is actually segment 2 and 3, so it's quite a chunk.
Yeah, and the caudate lobe was also quite big as well.
Caudate lobe is also quite chunky.
Yeah, I think that's a good point to make there, Prof. I think a segment 6-7 resection wouldn't have taken much more parenchyma, or even a right hemiapatectomy in a case like this. Yeah,
we don't worry about that when we do tumor surgery for colorectal metastasis.
Yeah.
But I think that especially the Japanese are sort of quite strict on that one, and we don't always do it clearly. But if possible, that one should sort of get the lymph or the possible drainage area of the portal vein
Yeah.
by it as well. I don't know, Onisa, any comments from your side? Yeah, I see you've got your hand up.
Yes. Yeah, sorry. Yeah, I was saying that looks like a very small tumor, and probably a local resection will be fine. I hear you, Prof, talking about a segmental or hemihepatectomy. But considering this is a very diseased liver with chances of recurrences or other metastatic, other HCCs coming up in the other segment, would a parenchymal sparing resection with a good margin, I would probably think that would be a way to go, because he has got a chance that he can develop another one somewhere else because his liver is already diseased anyways, which increases the risk of HCC.
Yeah, so I mean, those are the things that you have to consider. I mean, it's really individual decision making. So I think the first prize would be that you take the wedge of the parenchyma peripheral to the tumor. That would be at risk of local recurrence. But if there's underlying pathology, I mean, the patient will be at risk of developing tumors in the new liver as well. It's just a way of, if possible, I think that's the way to go. If not, I mean, you have to settle for something less. All right. Any other comments on that, Rashid?
Sorry, Karen. I just wanted to find out what is the max diameter of the lesion. So I might have missed that.
It's about 3 centimeters, Rashid.
Yeah, and I was just wondering, any ablative procedures, have you considered that, or will that
No,
be an
so-
option in this patient?
So we have ablation available, but not. We actually only have radio frequency at the moment, not microwave, and we're working on getting
Okay.
microwave ablation as well. I think the interventional radiologist wouldn't have wanted to go in and ablate that lesion because of the access, and the position of the lesion sitting so posteriorly, and it was pretty high up. So
Yeah.
our interventional radiologist was a bit worried about that. And I thought that the best outcome for him would be if we could get it with a good margin. Then
Okay.
yeah.
Cool. Thanks.
Thank you.
I'm also thinking that in the long term, this would be a patient who would be a good transplant candidate as well. Because he stopped his alcohol. He's been alcohol free for about 5 years. With a 3 centimeter lesion, he does fall within transplant criteria also.
Yeah, I think the patient would. I mean, we would probably, if the patient is a surgical candidate, still opt for a resection first, and if possible,
Yeah.
as I said, a segmental resection, and then see where we go.
Yes.
But certainly, I would be hesitant, as you mentioned, just eyeballing this. I think it's just a bit over 3 centimeters, and the position you're on the diaphragm, you will have to distance, get some distancing there, not to damage the diaphragm in this case.
Yeah.
I just want to go back to the previous case. Igembe, do you want to unmute and ask the question yourself, or should I just read it? Or sorry, ask the question. So I can maybe just do it. So he asked if it's okay, is it okay to conclude that this patient has got HCC radiologically in the absence of cirrhosis or HPV infection? My understanding is that LIRAD's conclusion for HCC requires the pre-existing HPV or cirrhosis, where the positive, the PPV, not quite sure what the abbreviation of that is, a positive predictive value, justifies the radiologically diagnosis alone. So I think that was mentioned before as well, that one of the sort of something like a testis cancer or that is not that sort of relevant in this case, or some of the other germline or genital tumors can give that. And I think that's why we had the discussion around the biopsy is before we embark on something very dramatic, not being quite sure about the diagnosis, this is maybe a patient where we should bite the bullet and do a biopsy to see exactly what we're dealing with, and then preferably through normal liver, because it is a borderline situation. Like I said, I don't think it's a big mistake to do a TACE on a fibrolamellar, but certainly if it's one of the other blastomas, it's a different ball game altogether. All right, I don't know if there are any more questions or comments. Otherwise, we're pretty much on time. The case that Nasser wanted to show down here is still stuck in theatre, and we are over time, so we'll save that one for another day. Anybody else with any comments? I don't see any more in the chat. So if not, thank you very much to the colleagues that submitted cases. It was a very nice discussion. Again, just thank you to GECHO, University of New Mexico, and also the India team that are always with us. You can also put some feedback on the sessions on the chat. We would like to improve these sessions and make them more relevant for everybody. And then also thanks to Karen and Cheryl, always doing the logistics for us. Thanks to all the presenters and then the sponsors, Takeda, Asino, Amgen, Equity, Aspen, and Adcock Ingram. Then these recordings are available on the Gastro Foundation website as well. And then just next week's meeting is going to be on IBD, and you can see the presenters there. So you're welcome back for nice discussions on IBD next week. Thank you very much.
Thank you, Prof. Thank you.
Thank you. Thank you, everyone.
Vanessa and Rashid, good to see you as well.
Good to see you.
Likewise, Karen.
Are we seeing you next week,
Cool.
Karan?
Yes, we are all seeing each other next week.
Fantastic, fantastic.